my Brazilian colleagues can help me.
We will help you, don't worry. And you can take your time. You don't have to hurry at all. You can take your time. So that's also very good if you feel a little bit nervous, to know that you can take it slowly. You don't have to rush.
Oh, thank you.
So Sarah, you are between friends.
Between friends, among
Thank
friends,
you.
exactly.
Yes.
But always that I need to present, I became a little nervous, but in English is the worst.
Yes, I have noticed that I always used to be a little bit nervous when I present, but I mean, doing it in digital, in Zoom, and I'm not that nervous because it's like, I don't know, it's a different feeling. You don't have the people here. And so I have noticed that I'm less nervous when digitally. Have you presented digitally before in English,
It's
Shusara?
the first time. No, it's the first time that I present in English. This
Oh.
week I present for my colleagues. All colleagues. Oh, you need to see my presentation.
Yes, I hope they will
These are
join.
my friends. You need to see my presentation.
Of course, of course.
Training the best way.
Yes. What is your background? Are you anthropologist or sociologist or epidemiologist?
I am geographer, but
Geographer.
I have worked with epidemiology for a long time, since I was in the under degree. So almost 15 years I have worked with epidemiology, health geography especially.
Yeah. Is it like contextual factors and this kind of?
Yeah. Social and environmental determinants. It's my specific area.
Yes, that's really interesting. So this is also the topic of the network that we have here. So it's always has been like social inequalities in health, social determinants of health, looking at upstream and downstream factors. Like upstream factors or middle factors are like contextual factors that are also very important. So it's interesting.
Yeah, she's my colleague. She worked with this, worked in this research with me and André Felici.
Okay. And yeah, I know one Brazilian researcher. Now, right now, I don't remember her name, but she used to work together with Dora Shore with this kind of. I think she's a geographer too. Maybe you must know her, but I don't know her name.
Not. I don't know.
Sharel, do you mean? Sharel, are you talking about Sharel?
No, not Sharel.
Dora Shore.
Brazilian.
Dora Shore. Dora Shore. And I think this person was Dora's doctoral student, and she's also into geography. So
not sure if she is geographer, because the number of the geographers from Fiocruz is very small,
very few,
maybe, and I know everybody.
You know everybody. It's a small world. Yeah, it's a good combination to understand the contextual factors. So,
hi, Suzana.
Lúcia, fala.
Como eu devo apresentar o grupo sueco?
O grupo sueco?
O que eu falo sobre ele, sobre a música? É do lado de fora mesmo.
Sabe, os músicos vão explicar um pouquinho de sua música, vão tocar, mas você pode falar que são folcloristas, música folclórica de Suécia, folkloric group.
Folkloric group. Okay.
Modern folkloric.
Então,
typical Swedish.
Ok, típico Swedish. Então, Suzana, eu vou começar dizendo que vamos ter, além das apresentações, a música. Aí eu apresento a Jussara. Depois da Jussara, vem 15 minutos de música. Depois eu apresento o Micael. E depois eu me apresento e continuo, não é isso? E você faz o final.
Eu vou fazer final. Eu tenho um par de slides que vou mostrar. Vou falar de nossa colaboração e tudo isso. E vou finalizar. Vou mostrar algumas fotos de nosso workshop no Rio de Janeiro. Tudo vai sair muito bem. Estamos animadas.
Estamos.
É nosso primeiro webinar. E, graças a Deus, temos a Camila, que é organizadora técnica.
Hoje temos 60 pessoas na lista.
Como? Rosane, bem-vinda.
The list of participants grow up. Today we have 60 participants.
Filhinha, eu estou tentando mudar a posição do computador para melhorar a claridade, mas não resolveu.
Ô, Lúcia, você tem um abajur?
Porque a gente tem que... Eu tenho um abajur.
Então, eu estou com uma lâmpada aqui e uma outra... O celular também funciona, colocar... Fazer um mini estúdio.
É porque, por exemplo, você, Jussara, está bem clarinha.
Sim, você está muito bem.
E isso deforma o cabelo. Você sabe que o cabelo é a parte mais importante da mulher.
Claro. Ainda mais para quem tem cabelo cacheado, né?
Olha aqui.
Eu quero resolver esse assunto.
Eu lembro quando eu estava estudando português, língua portuguesa, e aqui em Suécia, e professora brasileira, e eu perguntei à professora, podemos ler alguns artigos sobre a vida social da sociedade brasileira para entender melhor. A próxima vez ela vem com um artigo sobre a beleza, como importante cuidar do cabelo. Eu queria saber sobre literatura, cine, essas coisas interessantes. Mas
tudo bem.
Todas essas coisas são importantes.
Sim.
Vai dar certo.
Mas não aprendi muito bem a falar português.
Fala muito bem.
Você fala muito bem.
É muito forte, mas estou trabalhando ainda. Agora com Camila posso falar.
Sem erros.
Você entende, não? Você pode entender.
Sim, muito bem.
Mas o cabelo continua deformado.
Fica, Lúcia, fica meio deformado mesmo.
É a imagem.
Fica meio deformado mesmo, os cachos.
Pois eu vou perder o charme.
Quem tem cabelo cacheado fica deformado, ele dá uma...
Pois não gostei dessa parte. Tudo bem. Ai. Pode, Marinha.
Vou tirar fotos de vocês, tá?
Tira fotos.
Eu vou rir.
Mas por que você está escondida, Rosane?
Porque eu não sou palestrante, eu sou
participante.
Mas você está...
Fala alguma coisa, Camila. Camila, você está escura. Bota um celular para eu tirar uma foto.
Peraí, vou botar o meu abajur aqui, peraí.
Eu pareço uma fantasma com muita luz na cara, mas...
Não, está bela. Sara, fala alguma coisa que eu tiro de você, que aí você aparece.
Eu? Tô aqui.
Isso, fala...
Oi.
É isso. Vamos ver. Depois eu te mando.
Tá, obrigada.
Muito bom, Rosane, que você está fotografando, porque vamos ter essas fotografias para nossos resumos, para os CAPs.
Melhorou.
Fiquei melhor?
Sim, só que você precisa falar alguma coisa para você aparecer aqui na minha tela.
Tá, tô falando. Vê se vai agora.
Foi.
Para ser só o palestrante principal para aparecer, né?
Eu acho que tem como aparecer todo mundo, né? De repente,
mas é que a gente tinha acordado isso, lembra? Eu posso botar todo mundo, peraí.
Não, eu estou horrível.
Camila, uma coisa que eu gostei é que a apresentação fica na tela e a pessoa fica ao lado, quer dizer, que da outra vez eu fui apresentar e a minha imagem tampava uma parte da apresentação que eu precisava ler, entendeu? Me atrapalhei. Então, dessa vez...
Vê se você consegue ficar um pouco mais longe da tela.
Vê se foi, Rosane.
Espera aí.
Agora sim, deixa só a Lúcia se arrumar.
Mas eu não estou gostando desse cabelo.
Por que não aparece o rosto todo da Lúcia? Lúcia, você tem que ficar mais alta um pouco.
O rosto está aqui, Rosane. Está aqui meu rosto.
Rosane, está todo mundo agora?
Tá, sorriso. Foi.
Pronto. Rosane, por que você está escondida?
Não, eu não fiz meu cabelo, não fiz nada como vocês.
Mas você já é linda de natureza, não precisa.
Pronto, foi. O que vocês acham?
Pronto, vou mudar de volta.
Eu compartilho a minha tela agora ou espero começar?
Melhor esperar começar, né?
Tá.
Deixa eu só abrir aqui logo a apresentação.
A Lúcia vai falar um pouquinho antes de você, Jussara. Tá?
Assim, eu vou só apresentar.
Isso.
E cadê o texto?
A Letícia disse que está ouvindo tudo.
Sim, agora começou.
Então agora a gente não pode mais falar bobagens.
Mas eu tive que abrir, lembra, Lúcia? Porque ontem, como eu te coloquei como participante, hoje, para você conseguir entrar, por isso que você não estava conseguindo entrar. Eu tive que...
entendi.
Eu tive que terminar o wait room.
Camila, estou em quarto equivocado. Eu teria que estar lá com os participantes hoje. Não, vou finalizar.
Não, yes.
Mas temos que fechar vídeo, não? As pessoas que não falam.
Sim. Acho que sim.
Melhor, não?
Boa apresentação a todos.
Igualmente. Boa apresentação. Adoro essas apresentações. Boa sorte, Jussara. Animada.
Vai dar tudo certo. Vai ser... Eu estou super curiosa para ver. Eu tinha ouvido falar da pesquisa. Estou bem curiosa.
Eu também. Até pronto.
Até.
Eu vou esperar mais um pouco, né, gente? São 9 em ponto.
Sim, acho que dá para esperar uns minutinhos.
Como ontem, né?
Isso.
O que vocês acham? Começo?
Sim. Pode começar.
Good morning, Brazilian people. And good afternoon, Swedish people. It's a pleasure for me to be here today. We will go on our seminar, and we have today, besides 3 presentations, we have a Swedish group, a group which will show us folkloric music from Sweden. And this will be after the first presentation. Please remember that you all can make questions to presenters. Those questions should be included in the Q&A icon. I mean the question and answer icon. So you just have to write there your question and you will be answered. So this icon is in the bottom of your screen. And first, it's a pleasure for me to introduce you to Sara Angelo, a colleague from Fiocruz, and she's going to present some results of a research in favelas in Rio. Thank you very much, Sara. It's a pleasure for us to hear you.
Thank you, Lucia. Good morning, everyone. I'd like to thank you to invite me to participate of this important and interesting workshop. It's a pleasure to be here and share the results of our research with you. As Lucia said, my name is Sara. I am a researcher from National Public Health School from Oswaldo Cruz Foundation, and I am specialist in social and environmental determinants in health. I will share my screen with you first. 1 minute. Can you see my screen?
Yes.
The work that I present today is called COVID in Rio de Janeiro's Favelas, a shared production of knowledge. It was made with two more authors, Bianca Borges and André Pericer. They're also from Fiocruz, and they will help me to answer the questions in the end of my presentation. When the pandemic started in March, Brazil and probably other underdeveloped countries had a great challenge: how to control coronavirus in poor areas, in especially urban poor areas as favelas. All the strategies recommended to control the coronavirus are individual strategies like wash their hands or use hand sanitizer, keep distance from each other, wear masks, and hashtag stay at home. However, 17.7 million people in Brazil and about 22% of population from Rio don't have conditions to follow the recommendation because they live in reduced spaces where there is no sanitation, there is no tap water, the population density is high, and most of people work in a precarious job as a Uber driver and delivery. In the beginning of pandemic, we started to develop a methodology to do a epidemiological monitoring to favelas from Rio. However, we found some challenges, and the most important and the first challenge was how to give visibility of coronavirus magnitude in favelas if we don't have data available for this scale, because the official data are available just to neighborhood scale. And some favelas belong to different neighborhoods. Others are very small, and the hoods are also absolutely huge. And the favelas have different partners of social organization. In March, when the pandemic began, emerged many local initiatives from civil society to try to count the number of cases of COVID in favelas. In a movement called Hour by Hour, the social movements from favelas created many dashboards to COVID data. In this slide, you can see these initiatives, local initiatives. I'm going to explain with more details just one, Vozes Comunidades Dashboard, Communities Voice in English. But before that, it's important to understand about political context in Brazil and especially in Rio. The current municipality government has the responsible actors when they didn't plan specific strategies to control the coronavirus in favelas, and they don't give enough importance to scientific data, scientific information. So, but about Vozes Comunidades Dashboard, it's important to explain better what's the Vozes Comunidades. Vozes Comunidades is an online alternative journal that publishes news about favelas in Rio. They created a dashboard and an app to count the COVID data. In the first moment, some local services made available data for them, and the second moment they used the official data, but they separated the data for zip codes and per favelas. In this slide, we can see a synthesis of studies methodology that we chose to monitor COVID in favelas. We used three different approaches of health surveillance to monitor COVID. First, the traditional epidemiological surveillance that we use the official data from Rio de Janeiro municipality. Second, local territorial surveillance that we use data from Vozes Comunidades dashboard. And third, civil surveillance. Civil surveillance, that means talk to people from social movements that are the people who know a lot about favelas reality. It's important to say that these approaches aren't exclusive, but they are complementary. It's a way that we found to articulate different forms of knowledge. Now, in the next slide, I will explain with more details each one of them. As I said before, the COVID data are available just by neighborhood scale. For that, the methodological way that we chosen to analyze COVID's magnitude in favelas was classifying the neighborhoods. We overlapped the favelas map to neighborhoods limits map, and we calculated the indicator percentual of neighborhoods area covered with favela. The figure in this slide shows the classes that were created, and for these classes, you calculate rate incidence, rate mortality, rate lethality for all these classes. The second part of our research was calculate some indicators, incidence, mortality, and lethality. Use the data from Vozes Comunidades dashboard. However, to do this, it was necessary to compatibilize cartographical data from sensitive sectors and local health services, because you can see in the picture the limit of cartographic data is not the same. Because this, we had hard work to compatibilize cartographic data. Civil surveillance. Civil surveillance is a concept developed by Vitor Valla, who was a researcher from Fiocruz, also from Fiocruz, and for a long time he worked with social movements in Rio. This concept, civil surveillance, is based in the popular education from Paulo Freire's theory. It means incorporate popular participation in epidemiological analysis. In our research, we organized meetings to discuss the preliminary results of epidemiological analysis to discuss with the social movements the epidemiological analysis. The idea is to build with the favela and not to the favela. The results were analyzed in 2 periods and published through the 2 epidemiological bulletins. First, from March to June, and second, from June to September. It's important to explain better how the bulletins were organized. We're building the analysis with the social movements. For this reason, we would like to improve our communication with society, and especially with disadvantaged and vulnerable groups. These bulletins was written with informal vocabulary because we wanted it to be clear for the regular population. And besides it, we included the quantitative and the qualitative analysis. And it's important to say that since that we began to monitor COVID in favelas, we wish that our work was used to give support to social movements to fight for rights in health. And it's necessary to highlight that for us, information in health is a right. The graph shows the frequency of COVID cases per day according to the classification of the neighborhoods per favela concentration. The class with the highest occurrence in 2 periods analyzed was very high and high concentration of favela. However, these results must be analyzed with critical look, because until recently, the public health services was testing just severe cases, the patients that were in hospital. There weren't enough tests for all population. Other point that I would like to highlight in this graphic, especially in the second graphic, is that we can see many notifications from March, April, May, and June. There is a large delay in COVID notification. This delay makes it difficult to understand the tendency of COVID, because how can you say if COVID is increasing or decreasing if you don't have if there aren't data on time? In just one day, it was inserted in health information system 3,000 cases for previous months. The figure presents the incidence rate of COVID per neighborhood. It shows the peripheralization process of disease, because in the beginning of pandemic, the highest incidence was located in middle high social class, especially in South Zone from Rio, in neighborhoods as Gávea, Jardim Botânico, Ipanema, and São Conrado. São Conrado is not the South Zone, but West Zone, but it's a neighborhood middle high social class. In April and May, the incidence increased in some peripheral neighborhoods, especially in North Zone from Rio, as Bom Sucesso, Rocha, and Jacaré. These maps are from the second bulletin. In July, you observe that the highest incidence of COVID is in the neighborhood central, the downtown. We believe that this spatial partner is related to the reopening of the economic activities. August map, it's impossible to analyze because we know that there is a large delay in notifications. This map don't represent the reality. This figure shows the incidence rate in the neighborhoods classified per concentration of favelas. When you compared the results from first bulletin and the second bulletin, we can see average incidence in Rio reduced, and in the high and very high concentration classes, we also observed the reducing. But why did the class no favelas increase? To try and answer this question, it's necessary to look with more details, just this class, no favelas. The table presents the COVID cases in the neighborhoods classified as no favelas. We observe that downtown, Centro, and Leblon neighborhoods represent 50% of the cases in this class. As I said before, Centro and this neighborhood, downtown, is concentrated many activities, commercial and economic activities. And we have a reopening of these activities in June. Leblon is a middle high class neighborhood, so the residents of there have more access COVID tests because they can pay for it. In Centro, we don't have favelas, but we have other kind of urban poverty as tenements, and there are people living on the street and in abandoned buildings. The figure presents the mortality rate of COVID in Rio. We can observe that mortality has reduced in all cities, in all classes. This reducing can be related to improvement of COVID care protocols. We can see that the highest mortality rate was in low concentration. But why? Low concentration presents the highest mortality rate. The table shows the COVID cases mediana of class low concentration of favelas. Just two less of the neighborhoods are from North Zone, from Rio. All the others are located in West Zone from Rio, from the city. As I said before, the favelas present different spatial and social organization. The favelas from West Zone are very small if you compare it with neighborhood area. If you look at the map, I think that you can see better looking at the map. This map shows a part of West Zone. This region presents absolutely huge neighborhood area, a large area covered with vegetation, and the highest population growing rate of Rio. Besides that, is located so far from downtown, and the population used to take public transport completely crowded. Neighborhoods from this list are the low-income neighborhoods. However, they were classified as low concentration because there are methodological limitations in our study. About relation between race, ethnicity, and COVID. In the first epidemiological bulletin, we didn't analyze the COVID magnitude according to race because the way of filling out the variable wasn't complete. 45% of the data set was no data. However, in the second bulletin, the data complexion improved a lot, from 45% to 14.2% of no data. This improvement of quality information is related to lawsuits that required the variable race become mandatory in health information system. That is, to conclude a registration of COVID case, you have to put the information about race. The figure shows the news about this lawsuit. And it's very important to say that this lawsuit is resulting of actions of Black people movement. This graphic shows the incidence rate according race, and we can see that incidence rate is higher in Black people than white people in Rio. In the class no favelas, the incidence rate in Black people is 2 times higher than white people. And it's very important, relevant to say that 7% of the people who live in no favelas class are white people. And even then, who more get ill are Black people. About relations between gender and COVID. Men and women have a similar pattern of illness, except in neighborhoods classified as no favelas. However, men have a higher mortality rate in all social classes. About relations between age group and COVID, mortality rate is the highest in seniors groups in all classes, but we can see that in class called low concentration favelas present the highest mortality. And it's important to remember that the neighborhoods that are included in this class are neighborhoods located in West Zone. In this picture, we present the results of part we called local territorial surveillance that you use the data from Vozes Comunidades dashboard. We know that there is not enough tests, and this produces impact in our analysis, but we can see some relevant information in this table. We can see that the highest incidence and highest mortality is in Cidade de Deus. Cidade de Deus is located in West Zone. More once, we can see that West Zone has the worst indicators to COVID. This list, the list from right side, is the way that we found to give visibility to small favelas. Because when we had the meetings with social movements, some leaders told us, oh, the favela that I live, it's very small. When you show the maps, I don't know where we are. The TV all the time talks about huge favelas as Rocinha, Alemão, Vidigal. However, my favela, Catiri, we know nothing. Maybe I thought that if we don't exist for the society and for the government. For this reason, we tried to describe with more details small favelas, especially in the second bulletin. These are some testimonies of leaders from social movements. I will read. The first testimony is about Rodrigo told it. Rodrigo is a guy from Jacarezinho, and he belonged the social black movement. Oh my God, black people movement. It's an absurd the under-subjectification of tests. It's an absurd the under-subjectification and absence of tests for everyone. The private laboratories test who can pay, but in public health services there aren't enough tests. And when the people can have them, it takes too long to get the result. The government tries to give the impression that the situation is normal. Other testimonies is Itamar, he is from Santa Marta, favela. He told us, we have there to propose a new cartography which has the goal of getting close to reality with all the inconsistencies and uncertainties that we have. I think that this is our role and our mission, to dare even inaccurate and also in the uncertainties. I think it works make mistakes, but it also works to point to need and show possibilities for a new technical arrangement that can be able to get us close to the realities. To conclude, I am going to highlight 2 points. It's necessary to think deeply about the traditional structure of epidemiological surveillance, which has not been able to monitor the health situation in disadvantaged and vulnerable groups. Organizing health surveillance closer to the vulnerable people, particularly articulated to social movements and health local services, is the best strategy to control the COVID in urban low-income areas, especially in favelas. Unfortunately, COVID pandemic is not the first and won't be the last epidemic process of our society. In Brazil, in the last 10 years, we had dengue fever, influenza, yellow fever, Zika virus, chikungunya, and now coronavirus. And all of them, low-income people and Black people presented the high risk to get ill and to die. If the life conditions don't change, it will pass 30, 40 years, and we're going to discuss the same problems. To finish my presentation, I'm going to read a part of the test written by Hans Breyer, his important researcher from Ecuador. We need to give back to epidemiology its identity and ability to dream. Identity as science with emancipatory approach in the fight by human being and opposite to power which oppresses, and the ability to turn back to doing in different world, in which the researchers is strength, health at work, in daily life, in culture and political life, and in our relations with nature. Thanks. Hello.
Thank you very much, Jussara, for the good presentation, very provocative, and I have many ideas, many things to ask you. But perhaps you should go to the Q&A icon, please. You can read the question and for the audience to understand the answer.
Yeah, the municipality government available data in the panel data from Rio. I'm not so I will try to explain better. 1 minute. The CVAP data, the information, the variable race, you have in a notification, in a registration, you should put this information. But until recently, how I said in my presentation, we don't have this completude of this information, not good enough. And you use the official data from the CNAM, and Andrea, can you help me, please? Because Andrea is speaking better than me. And the question is, another curious, racial data you showed was based on CVAP data. How about the missing information in Rio de Janeiro and poor communities about racial information? I thought that I had explained about it in my presentation. In the first bulletin, we have 45% of no data in the database. And the second bulletin, this information improved a lot because the social movement pressures the government to put this variable to mandatory. About the methodology, and you take about the question is, thank you for your presentation, important work, Jussara. Could you explain a little bit more? How did you classify the favela small areas? Our classification, was it based on census population, data census, or other method? No, we took a map from Pereira Passos Institute, and we overlapped limits neighborhoods, and the map, the cartographical data from of favelas from Pereira Passos Institute. We overlapped and create an indicator, percentual of neighborhoods covered with favelas. It's the area that's covered with favelas. We know that it's a simple methodology, but for two things we chose this methodology, because it was easy to explain this methodology to social movements, and we tried some indicators because income from census data, but don't have a different results. The limitations of methodology, it was the same. For it, we know that there is a limitation, but it's the best way that we find to try to give visibility to COVID in favelas. Not sure if I was clear. Thank you, Leticia.
Jussara, you told that you wanted to give visibility of coronavirus magnitude in favelas in Rio. And I think you really did it. You managed to give visibility. And I think that this methodology of joining together epidemiological data, even with limits, and the voice from people and from social movements is very rich, because we can see the real situation. And sometimes we can repeat Martin Luther King and say, we have a dream. So you said about epidemiological dream and Braille and his ideas. So I'm wondering, I know it's a dream, but would it be possible that data from favela and all data we have on inequities in Brazil, we are a champion on inequities in health. Would it be possible that those data could influence the stratification for vaccination so that they could be a prioritization? Because for them it's much more difficult to obey the rules, you know. So perhaps if they could be also considered as well as other groups which are vulnerable. Do you think this is a dream?
Lucia, I would like that you ask me in Portuguese because some part of the questions I didn't understand very well. Could you explain in Português for me, please?
Será que esses dados de desigualdade não podem influenciar a lista das vacinas de tal forma na estratificação da vacinação da população, de tal forma que eles fossem considerados vulneráveis, como os índios, então? Just that.
Oh, I'm not specialist in this area, vaccine. Maybe André Perissé could explain better about it because he's a doctor. But I don't know if for this government is interesting to do it. The political contest is not the favor for the disadvantaged and vulnerable group in Brazil, the federal government, and especially in Rio, we have, you know, that we have many difficult, and in the last year, for example, the resource cut a lot of resources from health sectors, and the people that more suffer with it was the disadvantaged and vulnerable groups. And for this reason, in beginning of the COVID, these groups, vulnerable groups, suffering too much more than other groups. But it's a priority. I don't know if it's a vulnerable groups are priority for our government.
Yes. Thank you very much. I think we have another question here, a third question. No, it's just a comment from... You can read.
Oh, about second phase, Rosanne, she asked about the second phase of wave of the COVID. Oh, I think that for the people from Sweden, it's very difficult to understand the context in Brazil. But all the strategies to control the COVID in poor areas, in favelas in Rio, it was initiatives from civil society. In São Paulo is the same case. The civil society tried to control the COVID in favelas, and I can't see a perspective because to second phase it will be different for the first, because if you're not planning, you don't create a specific strategies, and I think the scenario is not good. It's not good. If you did nothing, you have nothing.
Yeah. André, would you like to complement with some?
Please, André, help me.
Yeah, I can help. So good morning. Just quickly, two debates that you actually brought, the vaccination and what I believe they are vulnerable population, but they are not the target for the first wave of vaccination, because this is a political debate, and it's right now the national government is trying to decide who is gonna be the first wave, and we actually have in the news some groups that are stronger than the others. They are actually debating to be the first. I don't believe this is only in Brazil. This is worldwide. The debate for the vaccine, and this is they actually, we have problems with the favelas to collect data, to know the comorbidity there. So our data is not very good for this areas, and they would need very strong influence in the parliament and in the national debate, and I don't think they have right now. So unfortunately, this is going to be they are going to be uh, not in the front line for the first wave of vaccine. The second one, what was that, Lucia?
No, it was just this question. There was a question from Rosani and Q&A, I think, about the second wave.
Oh, yeah, the second wave. We didn't have a second wave in Brazil. We are still in this first wave. So if we analyze the data, we're going to see that we had the increase of our case in May, and we're still on October. The beginning of October was still we still had high number of cases, and then a small drop, and now we're back on. If we compare our epidemic curve, it's similar to Mexico, for example, but and a little bit similar to the U.S. So we are not talking about the second wave. We are talking about an epidemic that has started in March, and we are actually getting more cases. So it's a different epidemic, and more beyond that, we have a continental country. So when you analyze different states, and even when you analyze different areas, local areas, you're going to see different epidemics. The south of Brazil, for example, the epidemic was in June, July, and in March, April in the southeast, north, and northeast. So it's a different epidemic. So, but it's one wave, it's one epidemic, and it's just getting back.
Yeah.
Yes. Hello, it's Susanna here. Shusara, because I can't write. I'm in the presenter side, so I can't write in the Q&A section. But I would like to state a question, if it's okay. I've been listening your conversation here. It's very interesting, and as you say, for us, it's difficult to understand the details and everything that affects the life in favelas, and certainly under these difficult circumstances that the pandemic puts us into. But I would like to ask you, Shusara, based on your expertise in geography and in social epidemiology and social determinants of health, if you were the Minister of Public Health in Brazil, tell me, what would you do now?
Oh, Suzanne,
for these vulnerable populations in favelas, and because I mean we are all related. I mean, even if we live in rich areas, I mean the virus doesn't respect any borders. It spreads, and we can't control that. So I mean, what are the priorities for vaccines? I have many thoughts, but I would like to hear from you.
Okay. For me, and I believe that for us, Bianca and André, also to invest resources in primary health care and local services it will be the most important in this moment. Obvious that the best way it was to try to change the live conditions, to give a good job, to give good life conditions. However, in this moment, in a short term, short price, it's important to invest in primary health care. And for example, I said before that the last year, the municipality government cut too much resource from health sector, and they fired a lot professionals, doctors, nurses in the local services, and in December of last year, and in March started the pandemic, and local services was completely destroyed, and we have important and big health services, and the universal health services, or SUS, and at the moment to increase, to improve the healthcare, primary healthcare, it's most important, because the primary healthcare, there's important role in low-income areas, especially in favelas. André, could you complete my answer?
Yeah, I would say social protection, because it looks like the federal government is believe that the epidemic is going to go away on December 31st, because we have a national budget. It's called War National Budget that ends on December 31st, and we don't have any budget for the next year. So I would say social protection, investment on local surveillance based on the primary health system. And we also need to invest on what we call intermediate settlements, where you can actually have some people there if they don't have any condition to keep distance and sanitation in their homes. Right now we have a crisis in our water system in Rio, for example. So this is something that it's unbelievable for this time of epidemic. So, and social protection ended actually. I think it ended last December was the last year when we had social protection for unemployment. And if we don't get this for the next year, then it's going to be hard.
And Susanna, and how I said before, as I said before, it's not the first epidemic process that we have in Brazil. If you talk to people that worked in 20,000 year in about the dengue fever, is the same problem, is the same, but it's not new for us. Black people die more, poor people get ill more, but for the future, it's necessary to invest in improve the life conditions. It's necessary. It's most important thing to do. That's it.
Yes, I think we have no more questions. Any comments, Susanna?
No, just thank you for your answers, Jusara, and a very interesting presentation, giving lots of information about the situation. We don't get that so much in news, so this is really like very important. Thank you.
Yeah. Now we will have a break, 15-minute break with Swedish music. So I invite you to come back on just a moment. I have to. 8 past 10, please. 8 minutes past 10. Okay?
Yes, and this.
Enjoy the music, the folkloric music.
Yes, and this is like a coffee break, and you can dance a little bit. You get like physical activity, move around a little bit. So we take a little break, and we have a really nice modern folkloric group for you, and they will present themselves and they will talk a little bit about their music. So I hope everybody enjoys. So welcome, Lena Jonsson with colleague.
Thank you. My name is Lena Jonsson, and this is Samantha Olanders. And actually, I'm Lena's sister-in-law, except I'm not married, but so we're kind of in-laws. Yeah, and we live in Järvsö. Maybe you can see a little bit of forest behind us here, and so it's in the middle of Sweden, or a little bit north in Sweden, in a small village. Around 1,000 people live here.
The Middle East of Sweden.
And we're gonna play some fiddle for you. And the fiddle is a very common folk instrument in Sweden. So we're gonna play some traditional music from this area. And we're gonna start with a tune called Friskt vatten, which means fresh water.
Well, I can see some clapping hands there.
We're gonna continue with another tune from kind of this area in Sweden. Actually, from after a fiddler from this town, Järvsö. He was kind of the big star in this area around in the middle of 1800s. And we're gonna play a polska, which is a traditional type of dance music.
Yeah.
After this guy. So he used to play it in the middle of the 1800s.
And we still play it today, hundreds of years after, but it's because they're so good.
Yeah. So here it comes.
I thought I would show you a little map of Sweden so that you can see where these tunes come from. and I'm gonna zoom out on my phone, and then now you can see where we are. Here's, I don't know if this is gonna work, but this is Sweden here. And if you zoom in
on the blue dot.
Yeah, exactly. That's where we are, in the middle, up there. So it's a very long country. So it's considered the north of Sweden, but it's really like kind of the middle.
Or actually just south of the middle.
Yeah, it's and we actually had some snow here a few days ago, but it just melted. So it's very sad. We were really looking forward to go skiing a little bit, but I think we have to wait a little longer before we can.
This weekend it's supposed to snow.
So yeah. Well, we're really happy. We have one more tune for you, and this is another polska. And the polska is a couple dance, and it's danced in. The music is in 3/4, and the dance is you dance like a couple. You walk around like this on the beats, and then you turn around like this, and the dance is just like in a big circle like this, and it's not as expressive as the dance in Brazil, I think, but
it's another type of
it's
polka.
Another type, and a lot of the tunes are in minor and a little bit more melancholic, but I really love the music from Brazil, and I wish I could play it. Maybe next time we can rehearse some tunes from Brazil and play for you if we dare.
And the polska dance type, polska actually means a person from Poland. So this type of dance music came to Sweden from Poland. So we say that we play really like traditional Swedish folk music, but really it's come to us from different parts of the world. So, and that's a thing with good culture will always travel, and as long as it doesn't know any borders, and I think that's a nice thing to have in mind when you say that you play traditional folk music, that it's probably come some other place from some other place here.
So we're gonna finish with a tune that's a very typical tune from this area. A lot of fast notes, and yeah, it's called Bas Pelles Eriks Brud Polska. It's a very long name. You can try and say it if you want. Bas Pelles Eriks Brud Polska, and it's from a fiddler from around here called Per Westerberg.
So I hope that you have a nice conference after we've finished here.
name is Samantha Olanders on fiddle, and my name is Lena Jonsson. And thanks for having us at your conference.
Oh, thank you so much. Thank you. So different. Yes. Oh, thank you. Thank you. And the climate's so different also.
Yeah.
Thank you.
Thank you. Have a great rest of your day.
Yes, have a good day also.
Likewise for you. I just wanted to say a little bit of the music that Lena Jonsson is so-called Riksspelman in Sweden, and that's like a person who masters the folk music. So we got the best of the best for you here in this conference. So have a nice continuous day up there in northern Sweden.
Thank you.
Bye.
Bye bye.
Oh, I think we should restart. So it's a pleasure for me to introduce Dr. Mikael Hostila from Stockholm University. He's going to present results on Stockholm relating to COVID mortality. Thank you, Hostila, Dr. Hostila. Thank you.
Thank you very much, Lucia. I will start by sharing my screen. Let's see.
People, don't forget to make questions in the Q&A icon.
So I hope you can see this. So during the pandemic, it has become evident that all groups in society are not equally affected by the coronavirus. Vulnerable groups, including ethnic minorities and migrants, seem to be overrepresented when it comes to infection and death rates. And we saw a presentation earlier, Yusara's presentation, showing this also in Rio. So today I will show some results on COVID-19 deaths by country of birth from Sweden, looking at differences across migrant groups. This is a study covering the first and most severe phase of the pandemic. At least we hope that it was the most severe phase, but let's see what happens. But I will also start to give you a brief background to the Swedish pandemic response and also show you some descriptive statistics on COVID deaths and infection rates in Sweden. And I think these results could be highly relevant also for the Brazilian context, given the large racial divides in the Brazilian society. And we saw that earlier on already in the presentation by Yusara. And I would be very interested in learning more about the Brazilian inequalities between racial groups, but also between other social groups in the Brazilian society. Perhaps collaborate on these issues. So I will start by saying something about the Swedish pandemic response, which has been discussed rather frequently in international mass media. Perhaps you have also heard about the Swedish context and how Sweden has decided to fight COVID-19. During the first phase, at least, of the pandemic, the Swedish COVID strategy was heavily criticized, I think, by both international news as well as several political leaders. And there was a widespread view that Sweden did not take this pandemic seriously, and that we did not take any measures to sort of reduce infection rates. I think Sweden was especially criticized since we didn't have a sort of a general lockdown of the society. And pictures like this one here on the slide, showing flourishing social life despite the pandemic, was broadcasted in international news. But I think most of these pictures did not really reflect reality and were rather stereotypical. I think Sweden took several measures to reduce infection and death rates. But an overall assessment is that a combination of bad luck, poor quality of elderly care, and that we were a bit too slow, especially in the beginning of the pandemic, has contributed to very high infection and death rates in Sweden. Sweden also focused most of its sort of pandemic response to behavioral recommendations, including social distancing, hand hygiene, bans of larger public gatherings, to urging people to self-isolate if having symptoms, and work from home if possible. But to a large extent, the society remained open. Restaurants, bars, stores, and shopping centers have remained open throughout the pandemic. But I also think that the Swedish emphasis on behavioral recommendations could, in the worst case, also increase disparities in COVID-19 morbidity and mortality, since lower SES groups and also foreign-born individuals and some groups of migrants might have greater difficulties in following these behavioral recommendations. On the right-hand side, you see a picture of a man called Anders Tegnell. He's the state epidemiologist in Sweden, and he's working at the Swedish Public Health Agency. And that is the man who has been leading the Swedish pandemic response. And it says "tvätta händerna," and that means wash your hands on the picture here. So let's take a look at some statistics then, showing the development in Sweden when it comes to COVID-19. This is the daily new cases in Sweden during the pandemic, from sort of February, March until November 17th. We have in total about 280,000 infected individuals. And we can see an increasing number of cases during the spring here. The number of cases then decreased in the summer months in Sweden, but started to rise again in the early fall. And now we have a very big number of cases again, which sort of suggests that we are now in a second sort of phase of the pandemic, second wave. But we can also see, when I show you the next slide, that these numbers do not correspond to the death rates in COVID-19. And this is because we had a very limited number of tests that were performed in the early phase of the pandemic. We didn't have enough tests, and there were big problems of testing. So the big increase in number of cases in October and November reflects both increased testing then, but also that we now have more COVID-19 cases again. This is the total or the development of the number of deaths in Sweden. We have more than 7,000 deaths now in Sweden. And as you can see, we had a very high numbers of deaths already early on during the pandemic, especially in April and May. And also here we see declining death rates in the summer months. and early fall, but now we see signs of increasing numbers of deaths, which seems to follow also the numbers of infected. I should also emphasize that the city of Stockholm was by far the most affected region of Sweden in the spring. Already early on in the pandemic, there was also signs of higher COVID mortality and morbidity in migrants and ethnic minorities, both in Sweden and also elsewhere, primarily in the UK and the US. In Sweden, we also saw that economically poor and ethnically segregated neighborhoods were more affected of the pandemic. They have higher death rates and infection rates. So therefore, I will now move to a study that we started to work on already quite early during the pandemic in May, studying COVID-19 deaths in different migrant groups in Sweden. So, despite the widely adopted message that the virus does not discriminate, there is preliminary evidence suggesting that the interaction between COVID-19 and the social environment does, pointing to a higher morbidity and mortality among low socioeconomic groups and also ethnic minority groups. This points out to an urgent need to study social and ethnic disparities in COVID-19 morbidity and mortality, and also to try to understand the mechanisms or explanations behind such inequalities. There are basically two main explanations for a higher COVID-19 mortality among certain ethnic groups. The first one relates to vulnerabilities due to a generally lower socioeconomic status among migrants, which in turn implies poorer social and living conditions. So not being able to successfully socially isolate due to low income or crowded housing conditions is then likely to amplify both infection and subsequently death rates. The second sort of main explanation relates to a higher prevalence of underlying risk factors in migrants, or a higher genetic vulnerability for infectious diseases, leading to a higher fatality rate. Pre-existing diseases or health problems in some groups of migrants, such as diabetes, high BMI, coronary heart problems, but also some adverse health behaviors such as smoking, low physical activity, or alcohol consumption could then contribute to higher death rates in COVID-19 in migrants. So there are some studies, previous research already early on in the pandemic, pointing out to ethnic, racial, and differences, and also differences by country of birth. A county-level study in the US found that counties with higher proportions of Black residents in the US had more COVID-19 diagnoses and deaths. A UK study documented increased risks of COVID-19 death for Black African, Black Caribbean, Indian, Pakistani, and Bangladeshi ethnic groups in the UK. And another study also found that compared to white people, Black individuals had a fourfold increased risk of COVID-19 infection, and that there was a doubling of risk among Asians and other non-white individuals. A final UK study found that Blacks and South Asian migrants in the UK then were more likely to test positive for COVID-19 and more likely to be hospitalized than white British residents. So the aims and research questions of our study: improving knowledge and patterns of causes of disparities in COVID-19 deaths across migrant groups, I think, is needed in order to design health policies to prevent excess mortality and morbidity in these groups. And most of the previous findings so far are not based on total population data, which would provide the most reliable knowledge base for health intervention. Therefore, the aims of our study was to document disparities in COVID-19 deaths by country of birth in Stockholm, Sweden. Second, to compare disparities with all-cause mortality disparities, excluding COVID-19 deaths during the pandemic. And third, to study whether socioeconomic status, education, income, and employment status, number of working age household members, housing type, and neighborhood population density attenuates disparities in COVID-19 mortality by country of birth. So I will mention something about the data and methods. We use a large total population database called Aging Well. It's an administrative data covering the whole Swedish population registered at some point between 1968 and the end of 2019. A register-based cohort including all adults living in Stockholm over 21 years between January the 31st, that was the date of the first confirmed case of COVID-19, and May 4th was utilized in our study, and we included people over the age of 21. In this data, 30% are foreign-born, and only individuals who had lived in Sweden for at least 2 years are included in order to exclude newly arrived migrants with limited information in the registers. All deaths from COVID-19 and all other causes of death between January 31st and May 4th were then analyzed. And we used Poisson regressions with region and country of birth as exposure and underlying cause of death by COVID-19 as an outcome. When we included population density in our models, a random intercept multi-level Poisson model was used instead, with something called DSO, which is a neighborhood division in Sweden, as the grouping variable. We also ran the corresponding models with all-cause mortality excluding COVID-19 as a comparison, sort of compare mortality risks in migrant groups between COVID-19 deaths and all-cause mortality. Something about the variables. Country of birth was grouped into 6 geographical areas: Sweden, other Nordic countries, other European countries, the Middle East, Africa, and the rest of the world. But we also analyzed COVID-19 deaths in specific birth countries. We included socioeconomic variables such as disposable income into quartiles, education, looking at primary, secondary, and post-secondary education, and employment status. We also included variables on living conditions specified by housing type, including special care homes number of working age persons in the household, and population density then at the neighborhood level, divided into quintiles. We also performed some sensitivity analysis to complement our main results. We fitted models considering the independent contribution of the mediating variables of interest to assess the relative contribution to immigrants' excess mortality risk from COVID-19. We also fitted models specifying an interaction between sex and immigrants' region of origin. We also stratified our analysis for ages 65 and under and 66 and over. And we also compared our findings with results on the entire population of Sweden, since we focused on Stockholm in these analyses. So turning to some of our results, this slide shows the distribution of COVID-19 deaths by day between first recorded death in Stockholm County and May 4th by nativity status. And we can here clearly see then that foreign-born individuals contributed to a large share of the recorded COVID-19 deaths already from the beginning of the pandemic, and has contributed to the deaths ever since. Moving on to sort of the main findings of the study, looking at differences by region and country of birth in COVID-19 deaths. This figure shows COVID-19 mortality risks in different groups based on region of birth, performed with Poisson regressions. And the results on COVID-19 deaths are shown on the left-hand panel. The right-hand panel shows mortality for all other causes minus COVID-19 deaths in the same groups during the pandemic. And the red dots that you see here represents the age-adjusted relative risks, while the gray dots are mortality risks when we have adjusted for socioeconomic variables, household factors, and neighborhood population density. And as you can see in the left-hand panel, based on the red dots, people born in other Nordic countries, but especially people born in Middle East and Africa, have very high death risks due to COVID-19 when compared to Swedish-born individuals. They have about, for example, people born in Africa have about 3 times higher mortality risks, and also people born in the Middle East. When the analyses are adjusted for socioeconomic and housing conditions, the excess risks are reduced considerably, but many of the groups still have higher COVID-19 mortality. So the mediating variables cannot explain all of the disparities in COVID-19 mortality. If we look at the right-hand side, we can see that most foreign-born groups have a lower mortality from other causes of death, minus COVID-19 mortality during the pandemic. And this clearly suggests that migrants are particularly vulnerable then to the coronavirus, since they actually have lower mortality risks from other causes of death. The next figure here shows COVID-19 mortality from other causes and from COVID-19 and other causes of death by detailed country of birth. So we have specified the birth countries here in this analysis. And we can then see that individuals born in Somalia, Lebanon, Syria, Turkey, Iran, and Iraq have particularly high COVID-19 mortality risks Socioeconomic variables, household factors, and neighborhood population density accounts for some of their excess mortality risks in COVID-19, but not all of the mortality risk. Higher COVID-19 mortality is also found among migrants from Chile, Greece, and Cyprus, and these excess risks are entirely explained by the mediating variables. If we look at the right-hand panel, mortality risks from other causes of death, excluding COVID-19, are generally similar or lower in the different migrant groups than for Swedish-born, especially in the fully adjusted model. So this slide results show sort of the same pattern, that these more specific migrant groups are particularly vulnerable to the COVID-19 virus. I can tell you something about the additional results from the sort of sensitivity analysis we performed. Of the predictors included in the models, we found that disposable income, employment status, and population density primarily contributed to the associations found, while housing type, whether people live in specialized housing or not, did not contribute. Female populations of the migrant groups generally had lower risk ratios relative to the men in the same group. However, socioeconomic and living conditions attenuated the risk more in male populations than in female ones. Outside of Stockholm, when we also included the rest of Sweden in our analysis, migrants from the Middle East and Africa had even higher risk ratios compared to Swedes, while they were lower for people born in other Nordic countries. And stratifying the analysis by age, below and above 66, revealed that the disparities observed were consistent across aged. However, the size of the ratios were much larger in people in young and midlife compared to old age in all these groups studied. So, to summarize the findings from our study, we found substantially higher COVID-19 mortality among migrants from Middle Eastern countries and Africa, but also among migrants from other Nordic countries when compared to Swedish-born individuals. We found especially high and persistent COVID-19 mortality among individuals born in Somalia, Lebanon, Syria, and Turkey. And differences in socioeconomic, household, and neighborhood characteristics explain between half to 2/3 of the excess relative risk in COVID-19. And all this then stand in sharp contrast to the results reported for all-cause mortality excluding COVID-19, where most immigrant groups have a lower mortality than native Swedes during the pandemic, which emphasizes that migrants are especially vulnerable to the COVID-19 virus. Some discussion and interpretation. Poorer socioeconomic conditions seems to explain some of the higher COVID-19 mortality in migrants. Poor socioeconomic position translate into occupations that are more precarious and more often found in the service sector, where personal contact is more frequent and the possibility of working from home is limited. So this could be a reason for the contribution of socioeconomic position to the found disparities. It is also well known that socioeconomic position is strongly associated with several diseases and health problems and health risk behaviors that could increase the risk of COVID-19 death in migrants. So the adjustment for socioeconomic position could therefore account for both risk factors inherent in low status occupations with more personal contact and underlying comorbidities explaining the higher COVID-19 mortality in foreign-born individuals. After adjustment for the number of working age people in the household and population density, excess COVID mortality risks were additionally reduced across the migrant groups. So migrants living and social conditions could then make social distancing more difficult, which then lead to a higher risk of virus transmission. And I would say in broad terms, the results align with the fundamental cause of disease theory presented by Link and Phelan, that country of birth and ethnicity is a fundamental cause of disease, in this case exemplified by COVID-19 infection and death. Similarly to most diseases and health problems, the increased risk of COVID-19 mortality in foreign-born reflects that those who are worse positioned with regard to important social and economic resources will be more afflicted by COVID-19 and the COVID-19 virus. And in general, it is crucial then to continue to study risk factors explaining migrants' higher prevalence in COVID-19 deaths in order to prevent such disparities both in Sweden and other countries with substantial migrant populations. I will briefly mention some of the strengths and limitations of our study. And these are, of course, also things that could be further studied in the future. But a great advantage in our study was the use of total population registry data with detailed information on the cause of death and information about COVID-19 deaths, and also socio-demographic information. But we could not directly study pre-existing health problems in individuals and how they vary across migrant groups in the registry data. So it would be desirable then to link data from hospital discharge registers, for example, to our data in order to investigate comorbidities as an explanatory factor for migrants' excess risk of COVID-19 deaths. There is also a risk of underestimation of the number of COVID-19 deaths in registries, since patients have to receive a diagnosis by a physician before the death. So COVID-19 diagnosis could be missing in patients with a rapid disease progression, and maybe this is a greater problem also in this first and more severe phase of the pandemic. And finally, information on genetic predisposition and genetic vulnerability, social interaction patterns, language proficiency, adherence to guidelines and information, and cultural and religious attitudes and norms regarding virus transmission could also contribute to the understanding of disparities in COVID-19 by country of birth. But we don't have that kind of information available in our registry data. So I would also like to thank my co-authors in this paper. The paper is currently being reviewed by a scientific journal, but there is a preprint available, and that is available if you follow this link where you can read the full study. Finally, I would also like to mention that I am involved in the Lancet COVID-19 Commission as a member of one of the 12 task forces. Our task force focuses on the public health measures to suppress the pandemic and is led by Professor John Cooley and Yuvan Oh. We are currently preparing a task force statement on our suggestions for public health and behavioral measures to suppress the pandemic. And our report will be included in the full commission statement that will be released in the beginning of 2021. And finally, thank you, obrigado.
Obrigada, Mikael. Thank you very much, Mikael, for your presentation. I think we have questions. Would you please answer them?
Let's see, yes. So a first question is if there is some specific social support, cash transfer program or specific health assistance from the government to immigrants during the pandemic. And to my knowledge, I mean, we have more general social support in Sweden in the form of welfare benefits and welfare programs, which could of course be supporting migrants. But we have not had any specific economic support and similar during the pandemic, other than there has been some local initiatives, for example, in poor neighborhoods with a high share of immigrants. They have tried different solutions, for example, providing temporary housing for family members to move to and isolate if other family members have COVID-19. So I think not any general sort of support programs, but there might have been sort of some regional ones. So the next question, I'm from Finland. How come Finns' mortality rate is high in Sweden, but mortality rate in general is among the lowest in Europe? I guess this is perhaps a more general question also. I think if we focus on COVID-19, I think the relatively high COVID-19 mortality rate is related to the fact that the Finns in Sweden are to a large extent working migrants. So they came to Sweden in the 60s and 70s to find jobs. So they are in general older and to a greater extent belong to risk groups. To the more general question of higher mortality in Finns, I think there could also be some kind of social selection of people or Finns coming to Sweden. Often, historically, they were factory workers and workers in the industrial sector. So they had lower socioeconomic position. So that could, in one way, explain sort of higher general mortality rate. And the third one, also about vaccination in Sweden. How about it? I think we have not yet started vaccination. What has been discussed is that we will start with healthcare workers and risk groups, and I think those will be vaccinated sort of during the first half of the spring. But vaccination will start rather soon, I hope at least. I think they have discussed something about 3 to 4 million Swedes that will be vaccinated before next summer out of a population of 9 million. But I think it's still rather uncertain about vaccination. but they will focus on sort of risk groups and older people and also healthcare workers.
Yeah, I think we have no more questions. I think Susanna wants to talk. I know her.
Yes, actually, yes. I would say I would have one question to Mikael. Thank you for an excellent presentation, very topical and giving lots of information about the situation in Stockholm area. But as I understood from your study, from your analysis and the models that you have, the variables that you have adjusted for, I mean, you had like if people are working or if they are unemployed. But I think that the work factors could give a little bit more hints in the differences between the risks that you find in these groups. For instance, we know that many foreign groups work as self-employed, like taxi drivers and self-employed have been very, very hard hit by this pandemic. And also the Finnish population and the other immigrant groups, certainly women work in the healthcare section, and those have been elderly care homes and this kind of. Do you have any comment on that?
Yes, yeah, you're right. I think we tried different models with specific occupations, but I think also the immigrant groups vary very much depending on the group, what type of occupation they have and what type of occupation are dominating. I know that the people that I did this collaboration with at the demography unit at Stockholm University, I think they have a paper now that I think it's published on looking at specific occupations and COVID-19 mortality. As far as I remember, if I remember correctly now, I think when they were adjusting for a number of other confounders, mediators, the specific occupation did not have that great effect or association with COVID-19 mortality. But it's an interesting study, and I agree. I mean, there are occupations where all these service occupations where people cannot socially isolate and work from home. The middle class can do that, so they probably have lower infection rates also because of that.
Yes, thank you, Mikael, for that explanation and pondering on those issues about working life. As work-life scientists, we are a few of us here. We, of course, want to highlight these aspects because they have a very high impact on people's lives. And you have heard these, like everybody living in Sweden, these anecdotal stories about how the pandemic entered Sweden, because very affluent people were in the Alps skiing, and when they came back at the airport, they took taxis, and the taxi drivers are those self-employed from poor areas, and that's how it spread to those poor areas. I don't know if this is true, but this is anecdotal, and people are telling this because they want to highlight these social differences in the population. So what do you think about that?
You mean who started the spread, sort of?
No. I mean, if you just, how do you think about this anecdotal information? We don't have any proof that it was like that, but it could be one explanation.
Yes, I agree, and I mean many of the migrant groups also work in elderly care facilities, and we know that the situation has been extremely severe, and there has been huge infection and death rates in the elderly care facilities in Sweden, which is a big also failure, and those could of course be the people, the migrants are to a greater extent working also in elderly care facilities. But I know actually that there is a Swedish commission now focusing and studying the Swedish strategy. And some inside information told me that they were actually planning to try to trace people through their mobile phones during the outbreak. Movements from, if people were abroad, if they were really in the Alps and then got infected and started the spread in Sweden. But I don't know. Some people say that the infection was already in Sweden and Europe a long time before we actually knew it. So it's impossible to say. But I think, yeah, you're right that we had this sports holiday in Sweden just sort of when the outbreak started, and that was sort of also a bit of bad luck for Sweden that it could have led to the big outbreak in Sweden.
Yes, thank you, Mikael. Thank you, Mikael, for the great presentation.
There is one more question.
One more, yeah.
Yeah.
Okay, it's in the. But I may have missed it. But were you able to adjust for multi-generational households, which is more common within migrant households? Yes, I think we actually did it. We tested a lot of different variables that we had available, and in this data, we did have information about number of household members that were in certain ages, but it didn't in the fully adjusted model. It didn't have a great effect on the associations, actually, which was a bit surprising because that was also one of our hypotheses.
I have a curiosity to ask you. You said that socioeconomic and living conditions reduce the risk ratio more in men than women.
Yeah.
What is your explanation for this or hypothesis?
Let's see.
I thought about working a type of occupation, perhaps, but you know.
Yes, it could relate. When I think about it, it could relate to occupations and working life, because in migrant populations, a large share or a larger share than Swedish-born women are actually housewives and working. I mean, they are not working; they are taking care of children and staying in the household. So that could be one explanation, that it's basically the men who goes out to work and provides, because they might, in some groups, they might have a more traditional sort of division between gender divisions in the household. But yeah, that is an interesting sort of explanation for that finding.
Yes. Thank you so much, Mikael.
Thank you. Thank you.
It was a privilege for us to listen to those results. Thank you.
Yes. Is it my turn now to talk, Lucia? Because, yes, I would like to welcome the next speaker, who is actually Lucia Hottenberg.
Yes.
And her presentation is titled "How to Improve the Work on Frontline of COVID." So please, Lucia.
Can you see?
Yes.
Yes. Camila, please, can you take off the squares here for me? There are squares in the screen for me. I cannot see.
It looks perfect.
Let me try. Okay, that's okay.
Now is okay.
So, okay, that's okay.
Okay.
It's a pleasure for me to tell you some results on mental health on workers on the front line of COVID. My name is Lucia Rotenberg. I work at Fiocruz in Rio de Janeiro in the Laboratory of Health and Environmental Education. So in those 2 days, we heard about the complex epidemiology and mobility of COVID-19. We also heard about huge health inequities, both in Brazil and Sweden, which were intensified by COVID. And now we are going to talk about mental health of those workers who are dealing daily with this disease. So we have here a paper from a Brazilian group from Ceará. And in the paper, they tell us when health professionals look death in the eye, and they described the several features of the disease and also the features of hospitals that attend those patients, so that we have a high perception of danger that contributes to pressures and concerns of health professionals. So we have acutely ill patients of all ages. We have a disease that aggravates very quickly. Workers have to care for co-workers who may become critically ill. We have the risk of infecting the family and all difficulties to deal with new or unfamiliar clinical roles and difficulties, as well as ethical problems. So we have here the risk of infection, the emotional strain, and work overload, so that the feeling of fear, stress, and many pathologies such as sleep problems, anxiety, depression, and burnout, it's very common in this population. So this is a data from Brazil. It's a print showing that data on insomnia show a high prevalence in this population, as well as anxiety. So I decided, together with a group, we decided to carry out our research aiming to analyze the mental health of workers, combining epidemiological techniques to a qualitative study. We joined together, we were together people from Fiocruz, from the State University of Rio de Janeiro, and from the Federal University of the State of Rio. So we benefit from this polyclinic, which belongs to the State University, which was one of the first reference centers for COVID testing in Rio. And there was a prioritization for healthcare professionals. So we had a banner in this place, and we also had the email of those people, and we asked them to complete an online questionnaire. So we could have a data bank with several professional categories, such as physician, nursing personnel, physiotherapists, psychologists, and so on. And people from different contexts, including primary health care, public and private hospitals, campaign hospitals, and so that we could have a good sample for the epidemiological study. And besides the epidemiological study, we have 2 other steps in the research. A step related to individual remote interviews with 80 people who were individually interviewed, and a remote group conversation, which is an ongoing step. Concerning our data bank, we have those data for describing the bank, mean age about 41 years old, mostly female. We have many people from nursing and several other professions. And we have some data on the perception of risk and some mental outcomes, where we could see that those outcomes, depression, anxiety, and stress, are related to the perception of risk. But in this presentation, I'm going to focus on the qualitative study, especially concerning workers from UCI and from COVID emergency wards. So in this qualitative step, we were based on the so-called work clinics, which is a set of approaches derived from psychology, ergonomics, and philosophy. And we could work with some concepts together so that we considered the relevance of workers' view on how to deal with work difficulties, and also the relevance of using this data to transform work as much as possible. So our objective in this step was to analyze workers' mental suffering in the perspective of understanding work to transform it. So we had the interview with several questions, such as the professional category, the type of health unit and sector. I have to explain you that in Brazil, healthcare professionals and usually health professionals are used to have many jobs, and several of them have 2 or even 3 jobs. And we have to ask about those different jobs. Changes that happen in workplace in relation to COVID pandemic, workplace support as regards the team, the management, the institution, the training possibilities, training in the use of protective equipment, the team performance, considering collaboration, support, and the possibility of having dialogues with people. A very special and important factor, which is the recognition at work and by home, by society, by colleagues, by the manager. We also talk to them about how to improve the workplace, which are the opportunities to change. Can they dialogue with the team, with managers about those changes? And we also asked them, what would they propose to change the work if they had total autonomy to decide? So what would you change in your work? We also asked them other things that they considered important. And also we asked them to describe the feeling of this moment in one word. So, although we didn't ask them directly about mental suffering, mental health, at several times in the interviews, they brought the experience of mental suffering, especially in relation to changes that occurred at the work, to what could be improved at work, and what they would change if he or she had full autonomy to decide. So, for instance, this physician told us the first thing she would do would be deal with humanization. I'm sorry, this is a nurse technician. She said, there is no humanization with the patient. There had to be a channel or anything that someone did to be able. The family has to have that contact. This physician told us about the overload and the feeling of not being able to provide a good assistance. So she said she would ask for more technical staff. She was in a ward that has 57 patients with only 2 nurses and 6 nurse technicians, which she considered an absurd. So it's too many patients for a professional. And if you manage to increase the staff by hiring more workers, it is possible to handle the work overload and also to change work shifts so as to offer more days off to relieve wear and to provide more pauses during shifts to favor recovery, to favor eating, and to better deal with the protective equipments, which are very uncomfortable to be for many consecutive hours. And because of this nurse technician had a praise for the head of the sector, because he said she divided, it was possible to divide the team and had a break where we stayed outside the unit, taking turns. So it was more easily to deal with being dressed all the time. I think it worked. I didn't feel worn out, he said. And here, when we think about workers' health and risks, this physician told us the question of really caring for the worker. I found an absurd on the first day not wearing a mask so as not to scare the population. This was very common in the beginning of pandemics. And this nurse technician told us, my God, am I going to have to be in a serious condition so I can test for COVID? Because she was not allowed to test COVID in the hospital where she works. So she was complaining very much about that. And as regards training, there were training in many hospitals, but unfortunately, they were not scheduled according to the possibilities of workers. So this nurse technician explained that trainings were scheduled for a Wednesday, but my shift was on Monday. And there was a day that coincided, but I was on shift that day, but I couldn't leave the sector. So that's very, very difficult because although there were training sections, many training sections, there was no concern about who were or not possible to participate in the training. So when we think about what workers would do to improve their work, they bring elements that would benefit not only their own mental and physical health, but also the patient assistance and the patient's family. In this case of a public hospital, the nurse told that there was no mechanical ventilation for everyone who needed. So she told that they had to practically watch the patient go there dying without having nothing to do. It's impossible not to be crazy with this, I think. So the mobilization of workers to deal with those demands makes them more vulnerable to mental health outcomes. And we know that this mental suffering is in the way between health and mental pathologies. And we know that in the interviews, the support from a psychologist was highlighted by many workers as a relevant action. But it's interesting because this psychological support not necessarily meets their needs, because they say, after all, everyone was attending home office. I mean, psychology, social work. So we miss the professionals there within the beat together with us. This is a physician who told us this. And this is similar to this nurse technician, because she thought that there should be a measure that every week, once a week, you have half an hour with a support group down there after the shift. And then she highlighted, we should be in group with people from the same shift. So it's interesting because this is very similar to some premises of our theoretical foundations, which is it's important for workers to talk about the work together, together with people from the same place to discuss the same experience, to think together about what is possible to do, how to deal with problems and difficulties. And so we have here the so-called rapid systematic review on interventions related to mental health. So the authors told us about that interventions described in literature seems to focus on relieving individual symptoms, but they emphasize, these are their words, healthcare workers were often interested in social support to relieve mental health impacts. Only a minority were interested in professional health for these problems. So they say there is a mismatch between the likely organization source of psychological distress, such as workload and lack of personal protective equipment, and how healthcare systems are attempting to relieve distress at an individual level. So we could see in the empirical material that there are measures that can be implemented by the hospital management or the sector management that can attenuate workers' mental suffering. For instance, if we think about training for protective measure, those trainings should include all shifts teams, including night workers, which are often forgotten in those situations. We should consider shift demands so as to plan the training in a moment in which demand was not so high. We should include workers who were hired later so that they could not participate in the first trainings. Simple things, simple. For instance, to improve the assistance, there should be a great communication with teams on night shifts. There could be different workflows thought collectively. There should be less bureaucracy for better patient care. This is especially important in private hospitals because they have many forms to fill because of goals and things they have to do. And because of this is a physiotherapist that showed that she doesn't have so much time with the patient because of the forms. And also when we think about how to provide a better assistance to patients and their family, there should be a support from social workers from the hospital, social workers from the hospital for the patient's family and the communication of the patient with the family. Of course, this is not related to all hospitals. These are measures that can be implemented, should be implemented in all hospitals to favor a good assistance. But when we think about the actions directly related to health and recovery, it should be possible to guarantee a structure with space to rest, to eat, to provide on-shift pauses for them to recover, to provide COVID exams as regularly as possible, to have a support of human resources and social work in cases of sick leaves, because many workers complain on the same thing. When they get sick from COVID, from urinary infection, or many problems, nobody from the human resources want to know about their health. They want only to know when they will come back to work. And this is difficult for them to deal with this. And psychological support groups could be implemented within the hospital so as to provide opportunities to work, to talk about their difficulties, to be together in this moment. So when we think about what could be made to reduce, to attenuate mental illnesses and mental suffering among those workers, we can think about ideal changes and possible changes. I focus here, I have focused on changes that are in the governability of management of the hospital and of the sector of the hospital. We know we have in Brazil changes that we would very much to be implemented concerning our public health system, which are much more complex and would be an ideal situation to have those changes. And so, for instance, concerning those perspectives for management, the main message of our research is that management, they are also suffering. We know they are also workers. The manager is also a person and a worker, but they should work together with all workers so as to value their work and to value the worker and the worker knowledge about the situation, and trying to identify changes that could be implemented, that are not difficult to be implemented by the hospitals, such as those that I talked to you about, training, about how to improve assistance, how to favor a better assistance to patients, and how to benefit workers' health and recovery. And when we think of work in pandemics, we know that the emotional impact is unavoidable. It is unavoidable, of course. But part of the mental suffering could be at least alleviated considering workers' health and knowledge. Because what we feel when we listen to workers is that the sense of a work well done emerges in the speech of them in a very deep way. And this is coherent with the premise of work clinics, which is our theoretical approach. The work is central for health. Our work is central, is essential for our health. So the sensation of providing a better system to lead the workers to suffer and possibly to get sick. So a registered nurse said, this psychological issue, because on the first day in that hospital, I slept crying. It was a huge neglect of the patients. So trying to talk about the complex changes involving the whole health system, we know that many problems stem from the so-called real SUS. SUS is the unified health system, a Brazilian health system that has had for the last year a chronic underfunding. And there is a phrase that touched me a lot. And I think that this sentence can synthesize the role of our public health system. The nurse said, because it wasn't just COVID that killed the patients, it was the lack of proper care. She is the one who slept crying because she could not give a good assistance to patients. So as is described by this author, a Brazilian author, he said the pandemic updates the defense of our unified health system and its principles of universality, integrality, and equity, as well as the way of guarantee the rights of the Brazilian working class, the right to access health services, the social protection. We told here about social protection in Rio's favela, the decent and protected work for health workers, and more than ever, the fundamental right to life. So we are in Brazil, we have a federal constitution that guarantee that health is the right of all and a duty of the state. At the same time, we have had and we have at this moment a limit for public health expenses. And this limit freezes spending and buries health. So I would say that it is about ethics. We are talking about inequalities in health. We are telling about poor people who die in a higher rate. We are not talking just about health. We are talking about social justice. And this is what we're talking about. So I'd like to thank you very much for your attention, and thank you very much, the team of interviews that make this research possible. Thank you.
Thank you very much, Lucia, for an excellent presentation and wonderful work. I can't imagine when you have had time to proceed with this big study with the quantitative survey and interviews, and it's amazing work and very topical. So I have some questions to you. You could perhaps stop sharing so we can.
I cannot. Okay.
All right. It
because
doesn't matter.
I cannot. Where is Lara? Me ajuda.
Lara
cannot stop sharing.
Anyway, don't worry about that. Don't worry about that. I can ask you.
Okay. Sorry.
That's great. Yes, there is a couple of questions in the Q&A function. You could start with those, and later I would like to come back with questions.
Okay. Yes, Rosane. In Brazil, we did not have the end of the first phase of pandemic. So health professionals have not yet been able to relieve from the intensity of work. How they will do to deal with a high workload for so long. This is very important, Rosane, because I heard a physician who told, I heard in the television, in an interview, he said, in the beginning, we had an overload, but the problem now is that we have another time an overload, but we are tired. We cannot get this anymore. So it's very important that something that should be, in my opinion, to deal with this problem we have now, an emergency program to make it possible to hire some new people to work with the patients. I think healthcare workers cannot give this support anymore. They cannot stand this anymore because there were so many months and now this again. And it's very difficult to think because we have many money problems and political decisions which does not prioritize health. We don't have a federal government that can integrate the knowledge and try to see the best strategy to deal with the challenges of this disease. So I tell you, I don't know how they will deal with this. My feeling is that they cannot stand anymore. They will be much more sick than they were, not only from COVID, but also from other problems, special mental problems. Let me see another question. Are there some plans in Brazil to end the future mental health problems long-term, such as the problems related to post-stress traumatic situation? I'm not aware of a program related to these problems. I think that we would need very much actions and measures to deal especially with this population. If we had a Minister of Health that could listen to people, to what science says about those people, I think perhaps there could be a special program from there. But unfortunately, I don't believe this. Perhaps in one state or other, but not in Brazil as a whole, unfortunately. Just to think.
And there,
no more questions. No more questions.
No more question. Then let me see. I do have some questions. Yeah, there is. Okay. Let me see. Here we go. Lucia, once again, thank you for your very important work. You presented so interesting results from these interviews here, and is the quantitative survey data under analysis? What are your plans to publish this research? Because the results are very important now, because these problems are common in this occupational group in the whole world.
Yes, our plan is to carry out the analysis in December and first fortnight of January. Actually, we are a little bit delayed with those analyses, but we are very interested because we have many different situations. So we can compare the sectors, the type of hospitals. And I think that it will be a very rich analysis. And we have many good plans for those analyses. Yeah.
Are you also going to be able to compare like private hospitals and public hospitals?
Yeah, we are going to. Of course, I have to tell you that the difficulties of this work is because the same person that works at a private hospital can also work at a public hospital. Mm-hmm. For instance, in the interviews, we ask them to focus on the hospital where the risk of COVID was higher. We try to do like this, but because sometimes they can work at a public hospital at the maternity and to work in a public hospital in the UCI. So in each case, we have to look at this. It is very complex because they can have more than place to work, but we are going to deal with this challenge. This is an epidemiological challenge. We are going to deal with this.
Of course.
But I cannot hide this.
No, it's the reality. Yeah. And you also highlighted in the results from the interviews that there is a urgent need for support for this occupational group on daily basis for them to be able to carry on with their very difficult task. So what are your thoughts about that? Are there any debriefing or anything like this taking place?
What I think is that actually we are writing a paper with all measures that were mentioned in the interviews and taking them together to distribute to hospitals. We have this in mind. What I think is that all hospitals have a team of psychologists, social workers, and perhaps those people should work at the hospital, not home office. Mm-hmm. I think this is not easy to decide because there are risks for them. The problem is that if you have supplies, if you have everything you need at the hospital, but you don't have people to work, it's impossible to take care of the patients. So perhaps it would be better to have social workers and psychologists together at the hospitals. I think we should try to think about that despite the complex situation.
Certainly, I agree with that. one more question, Lucia, because I'm asking so many questions because we have similar work going on at my university, at my department. So we would very much like to collaborate with you on this topic. One more question. Would there be any possibility for you to start a quick intervention, maybe a pilot or feasibility study about self-compassion practice for this group? Because to my understanding or in my experience, the self-compassion practice is very powerful, and it helps certainly in those situations when people are under heavy load of stress and when there is uncertainty. And we have talked about this topic before, I know, with Hosanne and you. So how do you see, would it be possible to do any intervention test?
Perhaps it would be. But what I think that the workers would benefit more is to have an opportunity to talk together with someone that could help them. But they could be together talking about their work. Because when we talk about our work, this happens to everybody. We can understand better. We can understand our feelings. We can deal better with this. I'm not sure which intervention would be better, but this is what they want to. And I think we have to hear them. But I like the idea of self-compassion. And I think the compassion is something we could feel in the interviews very much. Many times, if they could change something, they would change something to benefit the patients, not themselves directly. Of course, if you benefit the patients, you work better. It's better for you. But they think on the patients all the time. That's very important. We have to think about them also. Yeah.
Certainly, and of course, the most successful intervention is that one that is actually needed and asked for. So, and you have it very clearly in your interviews what this group needs. So, good luck with your work, and I'm very impressed. And hopefully, we can continue planning some collaboration here. So, are there any more questions to Lucia?
I think there is a question in the YouTube, but I don't know which is the question. Okay. I unfortunately, I cannot access the YouTube at this moment. Just a moment, Susanna. Just one moment.
Yes.
I'm
Lucia
sorry, because my
Lucia will get the question perhaps from the YouTube. Actually, this webinar is also possible to see in YouTube, and it will be there forever.
And
maybe.
I said YouTube. It's because I like YouTube. Oh, the question is, thank you for the presentation. Did you interview health workers who lost colleagues in their workplaces? The question sounds obvious, but the mental was likely affected differently. But how? Yes, we had interviews with people who not only lost a colleague, but took care of colleague at the hospital. And this was very, very difficult, very difficult. You can imagine. And so that's what happened. That's real life. Thank you for the question.
And thank you, Lucia, so very much for sharing these important results for us and highlighting the long-term stress that this occupational group is facing. And nobody knows how this long-term stress challenge is going to affect their long-term health. So your work has to continue.
Yeah, thank you. Thank you.
So, is it time for me to say some closing words, as we said? How about that, Lucia?
Yeah.
All right. So this was our last presentation of these 2 webinar days. And I would like to say some closing words. I would like to talk a little bit about our collaboration. I'm going to share some slides with you. So this collaboration that we have, it's financed by a program financed by the Brazilian CAPES and Swedish STINT. It's a joint Brazilian-Swedish research collaboration. They usually launch it in the fall every year. I'm not sure about the future now because of the situation with the pandemic, but it's open to all type of sciences if you have like a Brazilian-Swedish collaboration or if you want to start one. So the title of our collaboration is Social Determinants of Health and Aging, Occupational and Contextual Factors in Sweden and Brazil. And this collaboration started in June 2018, and it's going to end next year in June. And of course, we are hoping to prolong another year because we have not been able to do everything that we wanted to do during the pandemic. And participating universities in our collaboration from Brazil, we have the Oswaldo Cruz Foundation, we have Rio de Janeiro State University, and also University of Sao Paulo. We have researchers in our collaboration from all these universities and research organization. In Sweden, we have Stockholm University, we have Karolinska Institutet, and also now we are extending our collaboration to Mälardalen University, where I'm presently working. So these are our universities. And for this present collaboration, here are the key persons from Sweden. And from Brazil, we have Rosane Harte Grip, we have Lucia Hottenberg and Antonio Ponce de Leon. And from Sweden, myself and Mikael Rostila that presented recently. And what kind of activities we have had during the years, because this is actually our 3rd collaboration. And so we have had a long-term collaboration that has expanded and developed, and always we have developed new research questions and invited new fellow colleagues. But activities include yearly workshops. Usually it has been in Brazil, in Rio de Janeiro, in spring or this time of the year. And webinars. For the first time, we are giving a webinar. We have also had summer schools for doctoral students in biostatistics, in topics that students have had a need to learn more about. We also have doctoral and master students exchange going both ways, students from Sweden going to Brazil and doctoral students from Brazil coming to Sweden to spend time and to expand their networks and work here. And we have also senior researchers, postdocs coming from from both countries, spending shorter and longer periods. Together we are developing new research questions and also working on joint research grant applications and always expanding our network. And as I said, this is now the third collaboration that we have. The first one that was initiated by Johan Fritzell at Karolinska Institutet and Antonio Ponce de Leon at Rio de Janeiro State University. And that application started already 2007 and the project started 2008. And I was lucky to do part of my postdoc in Rio de Janeiro within the terms of that collaboration. So for me personally, this has been a great opportunity. And from the ongoing workshop collaboration, this is our latest workshop in Rio de Janeiro in April 2019. Nobody knew about the coronavirus by then. Everybody was lucky and happy, and we had both junior and senior researchers from Sweden and Brazil coming together. And we also always, at our workshops, we have international keynotes. So we had, at this time, we had from United States and from Italy. And the keynotes, usually we try to find people who have something, who are in a relative area, but have something new for us to learn, or also to provide interesting new collaborations. So it was a great workshop. We really miss coming back. And this webinar was organized by some of the key people here: Hosani Hertegrib, Lucia Hottenberg, Antonio Ponce de Leon, myself, and the very important person is Camilla Brecht in the middle of the picture. Here's Camilla is now a visiting doctoral student at Mälardalen University and she came here in September and is going to stay 1 year, and it's a challenge also to work now during the pandemic and trying to connect with people when it's mostly digital, but let's hope we can get back to normal doctoral meetings soon. So by these words, I would like to thank all of you, our wonderful participants. I hope that you have enjoyed our program. The presenters, thank you for very interesting studies, new analysis about this COVID pandemic that is on everybody's mind and affects everybody's life. Thank you for the great musicians. We know from studies from home workers that they complain that they don't get physical activity, they get tired. That's why we wanted to give you some music also, so you can get some cultural exchange and some happiness and energy. And of course, I would like to thank our financiers, CAPES and Stint, for making this great work possible. And we hope for a future that we can organize more workshops in real life. So thank you to all of you, and thank you for participating. Goodbye.